My dear people, how are you? This is Sam from Kenya. I'm here at Gleneagles, Mumbai, and I am with Dr. Anuraj Shrimal, a liver transplant surgeon. And I want him to explain what he does patient. He told me on a friendly basis he has been in this field or this specialty for 15 years. I would like you to listen carefully and know what it does in this specialty. Welcome, Doctor. Talk to people.
Thank you, Samuel, and a warm welcome to all my friends from Kenya. Welcome to Gleneagles Hospital, Mumbai. I'm Dr. Anuraj Shrimal. I'm the Director for Liver Transplant Surgery at the Gleneagles Hospital, Mumbai. As Samuel already told you, I've been in this field of liver transplantation for the last 15 years. I can proudly tell you that our hospital, the Gleneagles Hospital, Mumbai, has completed 1,000 successful liver transplants, the only hospital in Western India to have achieved this feat.
Doctor, with how many transplants?
1,000 liver transplants. The only center in Western India to have achieved this feat. And that is with best outcomes.
Wow. Very positive to hear this because people think it's impossible. Tell us more about liver transplant.
So, at our hospital, we have a very comprehensive program to take care of all aspects of liver disease. It begins with the medical care of liver, and that we have a department for adult hepatology as well as for pediatric hepatology. And we provide care for all forms of liver diseases, including hepatitis B, hepatitis C, fatty liver disease, very common now. And our team is available on teleconsultation for you as well for medical management of these diseases. We have got a very busy liver ICU where we manage the most complex of the patients, including the largest series of acute liver failures being managed in the country of India, successfully without a transplant, as well as the largest series for patients to receive a liver transplant for acute liver failure. Coming to the liver transplant surgery, our department is the largest department in Western India. We've completed more than 1,000 liver transplants. We have got an excellent track record of safety for the recipients and the donors. 100% donor safety is our motto. Okay. We offer robotic donor surgeries to the prospective patients who are coming to us. Even when some of the patients who opt for an open surgery, we do it through a small incision, just a midline incision. So no longer those L and big incisions in our unit. Okay. We've got the best outcomes. Nearly 95% of our patients get better and get discharged. We have mechanisms to follow up these patients on a long-term basis, including from faraway countries like Kenya, Ethiopia. We have operated on patients as far as Canada, Middle East, Dubai, UAE to name a few, Syria, Jordan, Botswana, a lot of countries from Africa, South Africa, all of these countries from the CIS, what is called Uzbekistan, Kazakhstan, countries like Pakistan, Bangladesh, from Southeast of Asia, Myanmar, Nepal. So it's truly a global program, and we have a mechanism to follow up these patients for a long term with teleconsult, so that you are never left alone. We are there to enroll you for your transplant while you are here, and we are there to provide you the care that you need back home at your country.
Well, thank you, Doctor, for telling us what you have done so far. I have a question. We have young babies who have this complication, and there are so many. What do you advise parents to do after they learn that children have got this challenge of liver?
Sure. So children are special. Remember, children are not mini adults. They need special care. We have a dedicated unit with our pediatric hepatologists, Dr. Borkar and Dr. Thambe as two strong pillars. We have a dedicated pediatric liver intensive care unit. Now remember, the babies may have different disorders. A common one which may need a liver transplant is biliary atresia, where the bile ducts are never formed.
Yes.
Sometimes they may have liver tumors like hepatoblastomas, sometimes metabolic liver diseases. Now, with children, what is very good is that most of the times one of the parents is a suitable donor. If they need surgery, if they need treatment for liver disorders, medical management, we provide it. If they need surgery, like surgery for biliary atresia, what is called as Kasai surgery, sometimes they have a condition called as choledochal cyst. The bile duct is dilated like a balloon. We have operated on as small as 2 kg, 2-month-old babies to salvage their liver. If at all the diseases progressed and now the only treatment is liver transplantation, like biliary atresia, failed Kasai's, recurrent cholangitis, some of the patients with liver tumors, hepatoblastomas, some of the metabolic liver diseases, Wilson's diseases. So with that, we provide the best care for the pediatric liver transplants. We have given 100% results for consecutive 60 patients over the last 3 years. That means that we have not lost any kid in the last 3 years. That's the kind of service we provide to the kids, and that's what I say differentiates us in the pediatric realm of liver world, not just adult unit getting adapted to a pediatric.
Okay. Doctor, there is also this common disease known as liver cirrhosis. How do you treat this condition?
Okay.
And what actually causes the liver cirrhosis?
Okay, so a very, very good question, Samuel. Now, liver cirrhosis. Now, what is liver cirrhosis? Is that liver is an organ. It is situated in the right upper side of your body. Okay, it's a very soft organ, as soft as your cheeks. Now, because of repeated long-term injury, let's say alcohol, hepatitis B, hepatitis C. Now what is emerging is fatty liver disease, obesity, diabetes, hypertension leading to fatty liver disease.
Yes.
Sometimes Wilson's disease or autoimmune liver disease, primary biliary cirrhosis, primary biliary cholangitis. These are all common causes in adults to cause cirrhosis.
Yes.
And in children it could be biliary atresia, it could be metabolic liver diseases, which can lead to cirrhosis of liver.
Yes.
Now, as you rightly said, how do we stage these patients and how do we treat them?
Yes.
Okay, now liver does multitude of functions, more than 500 functions. So there is no one parameter which can tell you where we stand with liver disease, and hence we use scores. One of the scores used is CTP score, wherein there are 5 parameters which is used: albumin, bilirubin, INR, ascites, hepatic encephalopathy. And with that, we grade the patients into A, B, and C.
Yes.
A is early liver disease, B is intermediate, C is advanced liver disease.
Yes.
In patients who have got early liver disease, they can be managed with medications. The span of time is around, say, 2 to 5 years they can spend in child's A. If we diagnose them, if there is alcohol, we need to remove the alcohol. If there is hepatitis B or C, we can treat it medically. Now, over time, these patients may progress to child's B and child's C. Where there is lack of availability of liver transplantation or services for complex liver patient, I say that anytime a patient is progressing from child A to child B, they should have a liver transplant early on. Okay. The medical management includes medicines, albumin infusion, salt-restricted diet. Liver transplantation is a cure for cirrhosis. That's the only cure. Medicines will not cure cirrhosis. Medicines can keep you stable for a shorter duration.
Yes.
Once the cirrhosis progresses, sometimes with cirrhosis, they develop tumors in the liver, what's called as hepatocellular cancers. So again, the only definitive treatment or curative treatment of cirrhosis with liver cancer or hepatocellular cancer is a liver transplant. So we kind of discussed about various etiologies of cirrhosis. We talked about how to stage, where I stand today. And we talked about medical management and a curative option with long-term cure that is called as liver transplantation.
Wow, that's good. Tell us more about hepatitis disease and how you treat it.
Sure. Now, hepatitis, what I think you're talking about is the viruses, which is the viruses which specifically affect liver. Okay. Now, they are classified into two broad groups. One is hepatitis A and hepatitis E, which are waterborne diseases. These are self-limiting jaundice most of the times, and most of us would have had it as a child or as an adult, and our body is capable enough to take care of them and get us cured out of it. So all they need is supportive treatment. The other group of hepatitis patients is hepatitis B and hepatitis C. Some of the uncommon is hepatitis D, though it's less commonly seen in our part of the country or even in Africa. It's more commonly seen in the CIS countries like Uzbekistan, Tajikistan, Kazakhstan, Mongolia. So it's a different area, geographic area to have that problem.
Yes.
Hepatitis B and hepatitis C. These are transmitted either from mother to child before birth, what is called as vertical transmission, hepatitis B more so. It can be transmitted between adults, which can be by sharing needles. It is with the blood and the body fluid. It can be transmitted by close physical relations. Now, they may not have any symptoms sometimes. These may be chronic diseases. In hepatitis B, after exposure around 80% of the times, the body is able to defeat the virus. So it produces a self-limited hepatitis. In around 20% of the patient, the body is not able to control it, and it may keep smoldering, progressing slowly over a period of time.
Yes.
And these are the group of patients who need treatment. Hepatitis B, now all children will receive vaccination. That's called as universal vaccination for hepatitis B.
Oh, that's good.
Okay.
Up to what age?
At birth. So they'll get it within the first few months of birth. There are 3 doses, and that's a part of the vaccination schedule. And it's a part of universal vaccination schedule. Okay. Hepatitis C. Now, hepatitis C is an RNA virus. Most of the times, if a patient gets hepatitis C, it will produce what is called as chronic liver disease. So hepatitis C has to be treated. Now there are good antivirals. Sofosbuvir, velpatasvir, a combination of the two of the drugs can cure hepatitis C. It's not that we put it to sleep. We remove it from your body. If diagnosed at an early stage, both hepatitis B and hepatitis C, hepatitis B can be controlled for a lifetime. Hepatitis C can be cured with medicines. Hepatitis B medicines is lifelong. Hepatitis C is a short course, and you are cured. Okay? In patients who present late to us with cirrhosis already, or sometimes they develop liver tumors, in those patients, we still give medical management, suppress the virus. Hepatitis B will go to sleep in your body. Hepatitis C will eliminate from your body. And then you need a liver transplant. So early, when you diagnose it early, hepatitis B and C, medical treatment only. When you diagnose it at an advanced stage, medical treatment plus liver transplant.
Who qualifies to give liver?
Yeah, very important question and very good question. Now there are medical aspects and legal aspects of liver donation. Medically, anybody who is above the age of 18, again a legal requirement, to the age of around 55 to 60-year-old can donate.
Can donate from 18?
From 18 to 50 to 60.
1 year?
No, not 18.
18 years.
18-year-old and above. Okay, below 18 you are a child. You don't have the consent to donate organs. Okay, so 18 years and above, up to a maximum of 50, 55, sometimes 60-year-old.
Yes.
Somebody who's as fit as you. Okay. You should not have any major medical or surgical illness.
Yes.
Then we evaluate the liver. Liver should not be fatty. We do the CT scan, we do MRI scans,
Yes.
and then we come to know who can donate. A blood group match is ideal. So what we call as compatible blood group. So suppose the patient has a blood group of O.
Yes.
Then blood group O can donate easily.
Negative, because negative or
Positive, negative doesn't matter. RH does not matter. So O positive, O negative both can
can
donate.
donate.
If it is
A.
A and O, positive, negative, all can donate.
Okay.
It's B and O, positive, negative, both can donate.
A, no.
Everybody can donate.
Okay.
If it's a universal recipient. Now remember, science has progressed,
Yes.
and we can do we can do liver transplants without a match of blood group also. So what I mean, that's what I'm coming to. So what it means is that, let's say we have a patient and his blood group is B,
Yes.
and we have a donor whose blood group is A. Okay?
Yes.
So the patient has got some antibodies to fight against this.
Yes.
Now what we do is that we check what is the quantity of these antibodies.
Yes.
We give a medicine named as rituximab. With that we can reduce the titers of this antibody. We stop the production of new antibody,
Yes.
and the preformed antibodies are removed by what is called as plasmapheresis or immunoadsorption.
Yes.
And once that happens, a blood group A can donate to B or B can donate to A. That's called as ABO incompatible liver transplant. It is very safe now.
Yes.
With the modern medicine, medications, therapies, it is very safe. It adds a little bit of cost because of the additional treatment required.
Yes. I agree.
Yeah.
Does it happen the same with kidney transplant?
Yes, it applies to kidney transplants as well. And our center, we have a team with Dr. Shah, a leading nephrologist of the country, and they are one of the largest series of ABO mismatch or ABO incompatible kidney transplants.
Yes. Tell us, doctor, now you have done liver transplant, you have donated, and how long does it take to grow? Because I was taught it grows.
Very good question. Now, liver has got two very important properties. One is liver reserve, and second is liver regeneration. So, reserve means that if I donate 70% of my liver, just this 30% is enough to take care of me.
30%.
That is reserve. Regeneration, this 30% which is left with me will grow back in as short as 1.5 months to 2 to 3 months. That's it.
1.5.
Yes. So the liver regrows.
Yes.
So if I have a kilogram of liver,
Yes.
I donate 700 grams.
Yes.
I am left with 300 grams.
Yes.
This 300 will grow back to 1 kilogram in as short as
Exactly.
1.5 to 3 months.
Wow, that is great.
What is the
With no
point?
complications.
No complications, and donor does not require any medicine or any precaution.
That's enough.
That's it.
Just like cutting the nail and after some time it grows.
Wow, very nice analogy. Yes.
So that is encouraging.
Yeah.
And what about the recipient? Does it grow?
Yes. So the healthy liver will keep on regenerating. So when we transplant a liver, we are transplanting a part of the liver. As per the recipient's body weight, this liver will also grow.
Yes.
And will be suitable and good enough for the recipient. And that's why liver does not have a shelf life. So let's say if you have a kidney transplant, this kidney can work for you from 10 to 15 years. And then you may require a second kidney transplant or dialysis. When you have a liver transplant, this liver keeps regenerating. So the life is endless.
That's good. I have another disturbing question, doctor. How long does it take for a liver to be transplanted from the donor to the recipient?
So your question is about the operation. So the two operations, the donor operation and the recipient operation, are going on in two parallel operation theaters.
Yes.
The donor operation takes around 6 to 8 hours to remove the part of the liver. 6 hours. The donor operation. The recipient operation takes around 8 to 10 hours. So we remove the liver completely, and we put the new liver in. We join the blood vessels. We join the bile duct, and then the liver is working.
Wow. How do you connect the veins, the blood vessels and the veins?
These are, that's what we are trained in. So very, very good question. We have special magnification eyeglasses, what are called as surgical loops. We have very fine suture materials, which are kind of not visible to your eyes directly. You need magnification to see them, and we join them very precisely. These sutures are inner sutures, so they will not cause a reaction even if they are inside a blood vessel or inside a bile duct. That's how you join.
How are they removed?
They remain in the system. They just remain in your body. They are inner. They will not affect. Not at all.
So, this technology.
Yes.
And you use robotic system, or you do what?
We use robotic system for donor surgery. So when we do the donor surgery using the robotic systems, we can reduce the size of incisions to bare minimal, like a phalanx steel incision, like a cesarean section incision. The recovery is shorter and faster and is pain-free. And I'll tell you one more thing. Even when we do an open surgery, it's through very small incision, like a midline incision. So we don't cut any muscles. And that also gives very fast and very good recovery for the donor. We have had an excellent track record of 100% donor safety in our series.
This is good. Doctor, as we went up, we have young men and women who wish to be doctors like you, who wish to do liver transplant specialty. How do you advise them?
So, that's very good and very encouraging. I promote learning. So we at our hospital is a teaching hospital. We have an accredited fellowship, what is called as Liver Transplant Society of India accredited fellowships. Only 5 or 6 spots are there available in the entire country. And we take one fellow every year, and we have got a hospital accredited fellowship where we take one fellow every year. And I encourage the young doctors from Kenya to come to learn with us. And my vision is that over a period we can collaborate with the young doctors from Kenya who come to us, who get trained. We can handhold them when they go back to Kenya. We develop systems in Kenya so that in the next 5 to 10 years, the young doctors are the superstars of Kenya, the super surgeons of Kenya.
Doctor, can you help in giving a sponsorship to needy student who wish to do liver transplant?
So the fellowship spots. Now this has to go to the government of India as well, because anybody who is traveling from a foreign country and receives a sponsorship has to go to the government of India. Our training spots are paid spots, so the students receive stipend.
So it is possible. Good. I'm going to arrange a few our young men who are ready to do this, especially in others, and because we need to grow also. You are our mentors.
Thank you so much.
We appreciate so much, and your efforts to treat our patients so much. I'm happy and grateful, and keep doing good. And may God bless you for that.
Thank you, Samuel. Thank you so much for taking the efforts to come to India, to Mumbai, to meeting us. And I look forward to meeting you more often. If the need be, come to Kenya for OPD. The best way we can help the people of Kenya, whether it is treatment, as well as the young budding doctors, where we can contribute in a positive way to the society. Thank you, guys.
Thank you, Doctor. Thank you.